This podcast is supported by The RealReal. Meet Christine. She loves shopping. And this is the sound of fashion overload. Too many fabulous things, not enough space. So Christine started selling with The RealReal.
I've always loved collecting designer pieces. Gucci bags, Prada heels. But my style keeps evolving. Selling with The RealReal? Game changer. I earn more, and they do everything.
Seriously, just drop off your items or schedule a pickup. We handle the photos, descriptions, pricing, even shipping. You just sit back and watch your items sell fast to our 40 million members.
And I get peace of mind knowing I earn more selling with The RealReal than anywhere else.
Exactly. That's the sound of your closet working for you. The RealReal. Earn more, save time, sell fast. And only for the month of January, earn up to $550 extra when you sell with The RealReal. That's right, up to $550 extra. Go to therealreal.com to get started. Earn up to $550 extra this month at therealreal.com. Terms apply.
Frequency Podcast Network. Stories that matter, podcasts that resonate.
2026 marks 10 years since the Canadian government declared the opioid crisis as a public health emergency. And with Health Canada investing more than $17 million as of a few months ago to fund research projects and harm reduction efforts, the strides to fight death by overdose are there. But the myths and stigmas of substance abuse have never been more prevalent. Ontario's relatively new heart hubs have kicked out 9 of the province's safe consumption sites as part of legislation passed by the Ford government to close sites that were within 200 meters of a school or daycare in an effort to boost community safety. But a recent study out of McGill University found that the relationship between crime and safe consumption sites isn't necessarily linear, and the effort to protect communities while taking care of the city's most vulnerable is possible, but way more nuanced than taking an abstinence-based approach. It all starts with getting on the same page with what community safety looks like, which we all know is easier said than done. I'm Maria Kestane, and today on The Big Story, we're talking to Dimitra Panagiotoglou, the Canada Research Chair in the Economics of Harm Reduction and Associate Professor at McGill University, to discuss the delicate relationship between stereotypes of crime and supervised consumption sites, and what kinds of conversations all levels of government should be having on this topic. Dimitra, thank you so much for joining me today.
Thanks, it's nice to be here. I want to dig in to your study to set the scene for this conversation. Tell me a little bit about your report and the results you found about crime around supervised consumption sites.
Right. So this project was initially motivated by the provincial government of Ontario's decision to transition from supervised consumption sites to what are now called heart hubs. And one of the key drivers behind that was a lot of the public's discomfort or otherwise dislike of supervised consumption sites with what I would describe as valid concerns around safety. And so being in research and not being one to take that kind of position one way or the other, we decided to look if there was a way to understand the association between supervised consumption sites and local crime. And we came across the Toronto Police Service's publicly available data, and were able to look at the associations of opening a site and crimes within 400 meters of those sites, comparing them to what was going on in those neighborhoods before the site had opened up. We looked at 5 major crime indicators, as well as bicycle thefts and thefts from vehicles. And there are, of course, other indicators that we were not able to look at because of issues with the kind of data available, and we can get into that if you're curious. Overall, we found that there was no consistent association between the opening of a supervised consumption site in a neighborhood and subsequent crimes. That doesn't mean that we did not find that there were regionally specific effects. So in some neighborhoods, assaults did go up or break-and enters. I will also say that overall, there was an increased association. There was an increase in break-and enters following the implementation of supervised consumption sites. So of all our indicators, that one did come out relatively consistently across all the sites that we looked at, and we looked at 9 sites in the city.
And what crimes were you tracking the data for? Which crimes?
Yeah, so we looked at assaults, break-and enters. I have a matter of like rhyming them out. Robberies, automobile thefts, thefts over $5,000, bicycle thefts, and thefts from vehicles. So some of those, as you can imagine, are quite severe crimes, and some of them are smaller. So like bicycle thefts are not the first thing that people worry about when they think about the safety of their neighborhood.
And why did you guys pick those crimes to track data on?
So part of it is the need to have enough of a count month to month to be able to say something about changes over time. And that's talking about sort of statistical power that we could have for neighborhoods and those indicators. But predominantly, we were looking at indicators that, one, are publicly available, so anybody can look in on them, and two, give a good sense of how safe someone feels within their neighborhood. Something like assaults and an increase in assaults would be a red flag, one would imagine, or break and enter similarly would be problematic. And this is also the kind of information that if you're thinking about moving into a new neighborhood, even purchasing a house, this kind of data is something that you might dig into to decide if this is a place for you and your family.
Yeah, totally. So you found that, among all the crimes that you were tracking, break and enters had spiked a little bit, but overall there wasn't much of a relationship between consistent increase in crime around these consumption sites. Why? What conclusions did you draw from that?
So I want to correct a little bit that, we saw about a 50% increase in break and enters, which is a non-negligible amount. Like that's pretty significant following the implementation of supervised consumption sites. It's hard to really understand why there was not a consistent effect in either direction. Association in either direction. We can't really say effect because this wasn't a randomized study. It was more of an ecological analysis. We do consider multiple explanations for why this may have happened. But I think the really interesting part is that in some neighborhoods, we saw no increase and subsequent decrease over time. And in others, we did see that there was an increase over time. And so what I think the public could take away from this is that there is no one-size-fits-all kind of solution to this, and that we could learn about neighborhoods and communities where this was integrated successfully on how to implement it should people decide moving forward to avoid subsequent harms to the neighborhoods that they're in, because I think that's a fair conversation to be having.
Yeah, we're now 10 years out from when Canada originally recognized the opioid crisis as a public health emergency, a priority that has seemed to take a bit of a step back after the Ontario government closed down the safe injection sites within 200 meters of a daycare or school. Before that decision last year, though, was Canada or Ontario, broadly speaking, I guess, making any sort of stride in effectively addressing that crisis?
Oh, this might be above my pay grade. That is a hard, well, truthfully, it's a really hard question to answer because there's so many elements to it. You can talk about, were we seeing declines in the number of people dying year on year? That's one indicator of making strides or improvements in this space. We could talk about the changes in the toxicity of the drug, right? So if they're getting less potent, if the drug somehow got safer, that would also be a win, which was not something we were seeing. But if that could be an indicator that you'd be looking for. We could be talking about the drug seizures and how much is coming in through different avenues, whether it be the ports or other borders in our country. And also the demand for those drugs. Is the demand itself going down? And that's something I think we really don't often talk about as much. And something that my team and I have been really trying to figure out is, what could we be doing to reduce demand for these kinds of substances? We know they're harmful, but we also know that once people develop a dependence or an addiction, it's really hard to get off of them, right? There's some interventions, particularly for opioids, but not for others. So ideally, you just want to prevent as many people as possible from starting. And there's a lot less talked about successfully what's prevented people from starting. There has been a lot of, I would say, experimentation in the harm reduction space in terms of keeping people alive and trying to get them to transition into treatment. But even with respect to treatment, with the exception of opioid dependence, we don't have a good arsenal of alternatives. So if you develop dependency to cocaine and other similar drugs, there's not a consistent treatment that works for everyone. And so then you're looking at something like abstinence, which is helpful for a subset of the population, but not for everyone. And then there's the bottlenecks and access to treatment itself. There's long wait times. You've heard about this repeatedly. And some of it's just because we lack the human capital There's just not enough physicians, nurse practitioners, other specialists who can meet the demand at where we are right now. So if we could stem the number of people initiating, that would be truly, I think, a win for everyone.
That's so interesting you talk about that because, as you said, a lot of the focus on this research is about harm reduction. And once it starts, how do we take it to a safer place? But a lot of the conversation lacks that initial, how to prevent people from even starting. What have you and your team been talking about in terms of measures to help prevent people?
Yeah, so it starts with really young people. And unfortunately, there are mixed results in terms of, different kinds of educational campaigns. A lot of the evidence we are working with comes from the states and the sort of just say no era, which we have a good sense of not having a successful track record. A lot of sort of the scaremongering kind of techniques don't seem to have long-lasting effects. What is surprising about some evidence out there is really if you don't focus on initiating drug use, but instead you focus on skills that allow for social mobility, social quality in young people, that tends to then lead to less drug use. So if you're giving people things to look forward to, really, in the most simple terms to think about it, potential job opportunities, education opportunities, relationship opportunities, and the skills to kind of handle setbacks, etc., those young people are better able to weather shocks of their lives and also not necessarily be as curious to initiate substance use.
You mentioned earlier that in some specific populations, that abstinence-based model, it does work. And that is kind of the basis of these heart hubs that we have here in Ontario now, the homelessness and addiction recovery treatment hubs. What does the research tell us about taking this kind of approach versus allowing for safe consumption?
So my understanding of the research and also speaking with people who have been in this space has been that really the most successful people have what is called high recovery capital. That means they have supports that will be there for when they exit the treatment so that they don't relapse. And the other element of this is that the individual has to be self-motivated, has to really be trying to get on the other side of this addiction. And so you can imagine that this is a really holistic kind of solution. They need to have a home to return to, job opportunities to return to, family members or other social members of their community that care about them, that will check in on them and continue to motivate them to move in the direction that they're hoping to. And that abstinence, there's never a finish line. You're just constantly working towards maintaining it. So it's an exceptionally difficult thing to do, but there are definitely success stories and it can be modeled. But there's so many things that have to go right that make it really hard. And that's not even discussing sort of kind of working through a lot of the traumas that lead people to self-medicate.
Yeah. In your opinion, do you think in Ontario we have that bandwidth to, check every box before putting someone in an abstinence-based model situation?
So I'm going to be honest, I don't live in Ontario anymore. I left Toronto about 10 or so years ago, although my heart's still there. And yes, I know Toronto is in the center of the universe, but when it comes to describing Ontario, that is my my experience, right? I'm talking about what I know for Toronto and not the rest of the province.
Totally.
I'd like to think that if we were to really first take a hard look at the resources that we have and think of creative ways in which we can both diffuse the services so they're accessible to all kinds of folks across the province, because let's be real, there are more services in cities than there are in urban centers, for example, in rural centers or communities, right? So that's one issue right there. There's a haves versus have-nots relationship to access. And if we could get really good at streamlining the process of moving people between different stages, right, from detox to and withdrawal management to treatment, which might take several months, to then skills redevelopment or whatever else the person needs. So once they exit sort of the more institutionalized kind of structure to just integrate into society, and that might include homes within cities that are sober houses, which we don't have a lot of information on. But these are all tools that we need to have a good sense of what exists, what has been working, so that we can then expand the model and hope to see true positive change.
Right. And what you're describing would require this robust, comprehensive interprovincial network of communication between, healthcare systems.
Yeah, just between services.
Yeah.
Right?
Yeah.
Between housing services and health services and mental health, and the divide between treatment that's publicly subsidized or provided versus privatized care, because there are folks with means who can access private care. But even there, it's a bit of a black box. We don't know who's coming in, who's coming out with success, right? So there's a lot of moving pieces and a lot of smart people working in this, trying first to just take like a snapshot of all our services that we offer and track people as they move through them and see where there are success stories and where people fall through the cracks.
Federal conservative leader Pierre Poilievre, dubbed safe consumption sites as these drug dens, which points to some arguments against the sites, claiming they encourage use and enable addictive behavior. What do you make of that argument? Because that is a relatively prominent argument against the use of safe consumption sites.
Yeah. So I know folks who lived rough, which means they lived on the streets, who were addicted to substances, who started engaging with supervised consumption sites and did ultimately recover. Some of them are now peers at similar sites elsewhere in the country. Depends on if they moved around or not. And I've heard of folks who never use these sites because they don't want anyone to understand or realize that they have an addiction of some kind. So there's examples where it works, and there's examples where it doesn't work just because the prime target, the person who would best benefit from this, is not going to use this service. And then there's this concern that they act as sort of like a beacon attracting drug dealing and all that kind of stuff. And a limitation of our study is we weren't able to find good data on drug seizures or drug-related activity near these sites. So I can't speak one way or the other to this. So that is, of course, a limitation. And my understanding is, I think that nuance that we were describing earlier in terms of the outcomes we've seen, this would be just another piece of that puzzle, because it's hard to imagine one kind of crime going up without other kinds going up as well.
Right.
I think break and enters might be a good way of thinking about what's going on locally if we are seeing sort of an influx of people with high needs for just stability, and they're not necessarily the most employed population, right? So they're looking for other avenues of income generating activity.
And, when you said, people themselves that need these services aren't using them, or they don't want to, they don't want people to think that they're using them. That all goes back to the stigmatization of it, the stereotyping, which, points to Pierre Poilievre's words, one of the most influential voices in this country, saying things like that. It really doesn't help towards breaking down those stereotypes and destigmatizing this population.
Yeah, and I think some version of supervised consumption should be normalized. Whether it's always use with a buddy, always have naloxone on hand so someone else can manage a poisoning event if it happens. There's so many other elements that are of concern to people's day-to-day lives that supervised consumption doesn't always take priority. I know of folks who have developed a dependence to opioids to manage pain, who are in the trades. And so if they were to have their addiction revealed, they would lose their license or ability to generate income, right? And so they fiercely protect that privacy. But many of them don't necessarily survive before they can access treatment.
Right.
And so that there's so much going on at the same time. And you could also argue as a member of the public who's not in the throes of these kinds of addictions, well, someone who has a substance use problem probably shouldn't be operating heavy machinery. But it's so much more complicated that this sort of black and white position, because then you're marginalizing this person further and further. and you're sort of like disengaging, pushing them out of the kinds of social ties and mechanisms that might otherwise lead to their recovery.
Right. The main argument for closing those safe consumption sites was that safety piece, that community safety piece, which, sure, community safety is very important. It's vital for families. But your study kind of debunked a bit of that myth, and this is such a nuanced conversation. What do you think is the missing piece that maybe the province of Ontario or other provinces or even families might not necessarily understand about this issue?
So I've really struggled with this kind of question. I think because in my recent experience with the media, this work has been positioned sort of as for supervised consumption sites, and so we're against communities' concerns, which is not really where we were coming from with this. We were really curious. We assumed crime would go up immediately after implementation across most of our indicators, and we were surprised to see there was no consistent association. And at the same time, we did not hide where it did go up. If people read the study, which is publicly available, and that was intentional, you will see that some neighborhoods, there is information on even just trend increases over time. And what might look like a small increase, so I'll give the example of South Riverdale and assaults, because it looks like it's a 1% increase month on month. But like interest, that compounds, so that over 3 years, you might see an over 40% increase on what was going on beforehand. So it's not to dismiss their concerns or suggest that they're missing anything. It's one that some of our work might be validating local communities' observations and concerns. And the other is to try and understand when it was working, why. I think the where it was working, why element is harder for any of us to get at, because it's about the sort of relationships that were probably developed in those neighborhoods with the community, with police services, what was going on to help support both the use of the services by people who needed them, as well as sort of to disrupt any potential harms that could have been exacerbated by the introduction of a supervised consumption site.
I mean, to that note, parents are in their right minds, understandably, they understandably want to protect their kids from maybe
Absolutely
seeing people in crisis or seeing people use or even, use needles. At the same time, though, the only way or one of the ways to help kind of solve this crisis on the right note, to make sure these stereotypes of people battling with addiction don't get passed on to the next generation. That missing piece is having those conversations, those nuanced conversations. What kinds of I guess, talking points or conversations do you think parents could be having with their kids at the right age?
So I'm not an educator in this space. I really can't speak for how other parents are going about it. I can say that living in a pretty urban part of Montreal myself, we are no strangers to seeing someone using right outside of a subway station, on our walk to school. There's homeless people, and just the first questions my kids ask are why. Why are these people living rough? And I try to explain that there's a whole host of reasons. People weren't given the same opportunities that we have been given. There's been a lot of harm in our systems, so they don't even trust resources when they do become available. And I try to help my kids see the humanity in people in general, without automatically sort of glossing over that there are opportunities to help others, to not just assume that this should be normalized and part of just everyday life, that we shouldn't be seeing this many homeless people. Like, that's not normal. We should be in outrage. We should be upset on behalf of people and wonder why we don't have the resources to solve this problem, or at least get really curious and involved in trying to resolve this issue, right? Like, it shouldn't be normal. It shouldn't be something that we just like walk over and kind of like ignore as it's part of like the periphery of what it means to live in a city.
Right.
And then, of course, substance use and where it comes from, and even just something as simple as people, I don't know how else to explain this. It's probably going to come off wrong. But the risk of experimentation is so much higher than it used to be when I was a young person. And that's really hard for people to admit that, yeah, there wasn't everyone who experimented, but if you did, the stakes were not nearly as high. Like, you might experience a poisoning or overdose. You might die, or you could survive, but with severe brain injury that leads to challenges with basic executive functioning. So if we're expecting someone to then show up for treatment day on day, and they don't have the capacity that the rest of us do at the same level because they've experienced this injury, that might be setting them up for failure. And so to understand that so many researchers have to come together to successfully help people, and we can't take credit for having avoided this entirely ourselves. Like, we are all connected. The fact that we see such deep poverty on our streets, there's a reason for that. We've made decisions collectively that are contributing to that and that we should be working towards resolving.
All right. Dimitra Panagiotoglou, the Canada Research Chair in the Economics of Harm Reduction and Associate Professor at McGill University. Thank you so much for this very important conversation today.
Thanks for having me.
And that was The Big Story. Be sure to send us your thoughts on this conversation at hello@thebigstorypodcast.ca or find us on Blue Sky @The Big Story. Be sure to share this episode with a friend or with someone you think may find it interesting. You can listen to The Big Story every day on the Seeker app or wherever you get your podcasts. I'm Maria Kestane. Thanks for listening.